So we're going to talk today. There's a number of different options for people with vestibular schwannoma. So vestibular schwannoma is basically a tumor of the inner ear, and it's a tumor that traditionally has been taken care of with a strong sort of multidisciplinary approach. You have neurosurgeons, you have neurotologists who are quite clearly essential for caring for these patients, and then radiation oncologists. So there's a number of different options here. What I'm up against today, what he's going to talk about, is really these some more recent papers, the best quality of the evidence, which granted isn't that great. Level 2 and 3 evidence shows superior outcomes for vestibular schwannoma patients having stereotactic radiosurgery. And so the dosage and the ways of delivering stereotactic radiosurgery have changed a lot since this literature, some of the literature that I'll present shows, but Dr. Nelson will have some of the other options there. And so currently, a lot of people recommend stereotactic radiosurgery. For this Cleveland Clinic where I came from, they irradiated everybody that had this. But that's still not necessarily the best approach always. And you do have to look at to some degree who wrote some of these papers. And so a lot of these papers, especially the more recent ones, this one was written by Bruce Pollack, who only does radiosurgery. So there's some bias in all of these things here. So this is what Dr. Nelson will do to you. Okay. This is radiation, so obviously I think everybody's familiar with that. And so when you look at any of these pathologies, I think you got to look at the goals of therapy and what one of your treatments is going to give you the best realization of the goals of therapy. So you get long-term tumor control, and so that's really the crux of the matter, I think, is that these patients have tumors, and you're looking at taking the tumor out and having the tumor not come back. In this particular type of tumor, though, there's a number of other problems that we deal with, and so one of those is hearing. And so a lot of the patients that come with these tumors, they've already lost their hearing. So those aren't really the ones that we're battling about here, because those have a little bit more clear pathway for treatment. The other one is the facial nerve. So the facial nerve is the nerve that runs from the brainstem that gives you facial motion. Okay, it's a motor nerve. And so if you've ever seen somebody with Bell's palsy, that's a facial nerve problem, or these kind of things. It can be a lot worse than that. So in the worst case scenario, you can't close your eye, and on whichever side we're talking about here. So that's a very devastating problem for these type of patients. So facial nerve preservation is key, regardless of what we're talking about here. And then really it's the limitation of complications. And so you consider these big surgeries that I'm going to talk about. There's a lot of complications that can come from that. Radiosurgery, you don't think quite about as many of these complications: bleeding, spinal fluid leak, that kind of stuff. But there are certain complications that come along with that as well. And we'll talk about some of that kind of stuff. I mentioned hearing. I thought about doing this entire talk kind of standing away from this so that you guys could experience the kind of hearing loss that Dr. Nelson will give you once he radiates your cochlea. But this is the sort of the scale that we use for hearing function. We as neurosurgeons don't use this quite as much, and as I mentioned, this type of pathology is really a team approach, and so you really need to have a good neurotologist. A lot of what I'm going to talk about here I actually learned from my mentor, my neurosurgical mentor, who's Dr. Buskaya back in Wisconsin, and he worked with a guy that some of you may know because he's here in Denver now. His name is Sam Goobels. He's an excellent neurotologist, and so I learned a lot of this stuff from those guys, and this is really the sort of the hearing scale that we use. And when you look at this, it's really serviceable hearing or not. Really the only question that I ask most patients when they come to clinic about these tumors is, can you talk on the phone on that side? And if they can talk on the phone, then their hearing is serviceable, essentially, and that's what we're trying to preserve. Once you can't do that, the hearing is really non-serviceable, and you don't really care about it that much because you can't use it for anything, so you have to use your other ear. These are really the three pathways. So we're kind of battling through surgical resection versus stereotactic radiosurgery, but there's the option of observation. And amongst those people that have taken care of many of these tumors, I was at the skull-based meeting a few years back, and Majid Sami, who's in Europe, he's operated on 4,000 or 5,000 of these tumors. it was saying that, especially in older folks with smaller tumors, they don't do anything. They just watch the tumors, and we'll talk a little bit about that. This is sort of some of the historical developments. I won't talk about this too much, but I mean, this goes all the way back to 1825 when you see some of these the older neurologists that will still do tuning fork testing and things like that. I don't think too many of us do that kind of stuff anymore. But that's where all this came from. And then we had MRIs, and now you have intraoperative nerve monitoring, and they have electronystagmograms and all sorts of things for diagnosis of these tumors that can tell us both what nerve they come from and what is involved. And so here's observation. This is what I was mentioning earlier, that is an option for some patients. So typically when we look at doing observation, I do have a few young patients that we are observing by their own choice, but typically this is a thing for elderly patients. Okay, so these tumors, they grow quite slowly. If you look, a high percentage of the tumors will grow, probably 40 to 50% of tumors will grow, but the growth rate is somewhere between about 0.5 millimeter to 2.5 millimeters per year by most of these studies. If they have lack of serviceable hearing, well, then once again, you don't care about the hearing, so at that point you're only really caring about the facial nerve. So if the tumor grows and they don't have hearing, they can still have facial nerve symptoms. However, actually most patients even with large tumors don't have preoperative or pre-treatment facial nerve symptoms. So that's not as much of a concern either. So patients over the age of 65 or 70, you very easily can monitor these, and it may never grow to a size that's going to give them a problem in their lifetime. And this is a meta-analysis of studies that with really 1,300 patients, which is a pretty good number for this disease process. Like I said, the overall growth in follow-up, 38 months was 46%, so nearly half the tumors would grow. And this particular study that looked at a number of papers, the mean tumor growth rate was about 1.5 millimeters per year. The entire internal auditory canal is only a couple of millimeters, though. So this has to be taken in context to some degree as to what constitutes a large amount of tumor growth. And they treated only 18% of the patients in follow-up. But in 38 months, that's not a very long follow-up. And part of what we'll talk about here, Dr. Nelson will try to convince you that all of the complication rates and the hearing preservation is better, but if you look at the long term, 10 or 15 years down the road, there may be some fall-off. So here's radiation. I won't talk a ton about, these are the options basically, but I won't talk a ton about radiation. Like I said, Dr. Nelson's going to talk about that. But if we're really battling here about patients that have tumors that are about 1 centimeter or 1.5 centimeters, okay, that have hearing, and those are the ones that you're not really sure what to do about those. If you have a tumor that's bigger than 3 centimeters that has a bunch of brainstem compression or hydrocephalus, those patients are going to get surgery, or they should. There really isn't another option for them. Patients that have tiny intracanalicular tumors, so intracanalicular means inside the internal auditory canal, those patients, with a few exceptions, those patients are very excellent patients for radiosurgery. They do very well. But it's really these patients that have 1 centimeter to 1.5 centimeters, that part of it's in the cistern by the brainstem. Those are the patients that we wonder about. And so then you have a number of different surgical approaches that we can use, and I'll show you those too, just so you don't forget. That's what he wants to do to you. All right. So here's a few of I can't talk about this entirely without talking about the side effects of everything. And so if you look, some of these papers are older, and as I mentioned, the dosage for radiosurgery has changed significantly over a number of years. They used to treat these up to 25 to 30 gray, and patients were having horrible side effects. There were high percentages, up to 50% were getting facial nerve palsies. Almost all of them were losing their hearing. That's a very high dose. So now, generally, I think the accepted dose to the margin is about 13 gray, and the complications with that are very low. But the problem here is that all of the stuff that we're talking about, all the facial nerve, the cochlea, all the hearing apparatus, everything is in a very small area. Okay, this is all inside the temporal bone. And so it's hard sometimes to get good planning so that the dose drop-off is good enough. But you can see a lot of patients, a high percentage of patients in this study got facial nerve palsies. A lot of those will resolve. And the same thing is true for surgery. But they had 100% control at 18 months with those doses. So you have a balance here between a high enough dose to control the tumor that won't cause side effects. So this is, again, I just have to show the things that Dr. Nelson can give you here. These are radiation burns. Okay, this is to the back. This is from a spine tumor. But this is alopecia caused by radiation, and that's a very real problem. Now, so Dr. Simpson's here, a CyberKnife or Gamma knife. This kind of problem is much lower with that because you're delivering radiation from a number of different angles. But these are bad problems, and a slightly worse problem here. It's hard to live with that, right? It's a real problem. So. Then you've got, if you talk about the radiation damage to normal structures, though, it's hard to know how this stuff works. All of this may play a role in post-radiation, facial weakness. A lot of patients will have fairly pronounced vertigo because you get delivered radiation to the semicircular canals and the vestibular apparatus. A lot of patients will have tinnitus. And so those kinds of symptoms after radiation are a little bit higher than after surgery. And if you look at some of the areas, I won't go into this in great detail, but if you look at the doses, a few of these papers looked at the doses that some of these structures would receive, that can play a big role in what happens later. And some of these side effects are delayed because this is probably a microvascular effect of radiation to some of these nerves. Really the one for hearing, though, is the cochlea. And I don't think, there's not great literature on this, but if you look at the cochlea, even with stereotactic radiosurgery, where the cochlea itself maybe doesn't get such high doses, at 10 or 15 years, a lot of patients will have hearing loss. Now, they may have that, some patients may have that with surgery too, because there's at least the thought that there's some microvascular changes after surgery that can also lead to cochlear hearing loss. I had one of the neurologists that I worked with here briefly. Actually, he tells all the patients they're going to lose their hearing. Doesn't matter what kind of tumor they have. He just tells them they're going to lose their hearing sooner or later, and it's going to happen. And so I think there's some probably reality to that as well. One more slide here, okay, for radiation. The one on the top is top left is Chernobyl. The other one's 3 Mile Island, and then the one on the bottom is the Japanese nuclear plant that just happened after the tsunami. So Nelson's got a lot of things to convince you of here. These are the cons. I think he'll talk a little bit more about that. But there's potential for regrowth. You're not taking out the entire tumor. So and matter of fact, most of the time you're just slowing it down, or you stop its growth. These are very slow-growing tumors, so they don't tend to regress as much as they do just kind of stay stable. You don't have histopathology. That's the other thing that you can get with surgery. I mean, there's a very small chance, but there's a chance nonetheless that this could be meningioma. This could be some other type of tumor. Probably also reasonably well treated with radiation, but we do like to know what we're treating. And then there's a few sort of specific complications you can have after radiation, which are one, the potential for malignant transformation. That's very low. I've honestly never seen that in my career, but it's a possibility. A chance of hydrocephalus, and then the chance for secondary primary malignancy. So patients that, I think that's a much less. I don't have a number for that, but it's a much less of a concern now than it was previously with the types of radiation that we deliver. But we do see a lot of patients now that got radiation 30 or 40 years ago for medulloblastoma that are coming back with many other sorts of primary malignancies, glioblastoma, meningioma, and those kinds of problems. So that's something to keep in mind at least. Now I'm going to go to the surgery part, so I mainly wanted to talk about anyway. And so when we talk about doing surgery, there's really 3 different approaches that we look at to take these tumors out. Okay, so 2 of them are for hearing preservation, so that would be the retrosigmoid approach and then the middle fossa approach. And then the other approach is called translabyrinthine. That's a classic sort of skull-based approach, but you're going to lose hearing for sure. So that's in patients that don't have serviceable hearing to begin with. The considerations for these are, like I said, the level of hearing, the depth of the tumor penetration into the internal auditory canal. That matters a lot because from the retrosigmoid approach especially, you don't get as much exposure of the internal auditory canal. So for tumors that are intercanalicular tumors that are entirely in the canal, that's not necessarily the best approach. Translabyrinthine, you get the entire canal exposed, and middle fossa, you get most of it as well. But some of the downsides are that, for instance, the middle fossa approach, you're approaching from the top of the temporal bone, and the window between the internal auditory canal and the cochlea, you have less than 1 millimeter to drill between there. And if you accidentally drill into the cochlea, the hearing is gone. So it's a very difficult approach, and that's why I mentioned you really need to have a good neurotologist. I don't do that kind of drilling typically, and they do, and so you really want to work with a good neurotologist. I think this bottom point here, the experience of the surgeon, is really, really a salient one. I think that, we were talking about this earlier, that if you are in a small community with just sort of a general guide, most people don't take these kinds of tumors out. Most people don't do these kinds of skull-based approaches, and so you really have to take into account what people are comfortable with, and so I think that's an important one. This is kind of an algorithm that we use where I trained. I mentioned, translabyrinthine, you're going to lose hearing for sure. So those are for patients that either have very bad hearing to begin with, or they have a very deep penetration of the tumor into the internal auditory canal. There are people, as a matter of fact, the guy that I mentioned from Europe earlier, that do 100%, they just do retrosigmoid for all of these cases. They're very good at it. And so I think that has to do some with the experience of the surgeon. But what we found previously is that the facial nerve outcomes, if you do, translabyrinthine, you get a better exposure of the internal auditory canal, and you find that one of the advantages of that is you find the facial nerve as the first thing. So you can preserve the facial nerve. These are very small nerves. Most of the time they're very splayed by the tumor, so that it's just a veil of tissue that's kind of running over the tumor. And once you get into that nerve, you have a lot of trouble, and the patient's going to have a lot of trouble afterwards. So you really select these approaches based on some of those kinds of things. For translab, I mentioned early identification of the facial nerve is key. You identify it distally out into the temporal bone, and you can follow it back to the brainstem, and that's actually a much easier way of preserving the facial nerve than identifying it at the brainstem and following it out laterally. Another advantage is that this approach is going directly through the mastoid, so the bone right behind your ear. There's really not much exposure of the cerebellum or the brain, not much retraction on the cerebellum, so the cerebellar swelling and things like that is much lower. You get great exposure of the internal auditory canal. And you have one of the main problems with a lot of these approaches back here, skull-based approaches, is spinal fluid leak. So we use lumbar drains, we use fat grafts and things like that for that. The disadvantage I mentioned, you're for sure going to have hearing loss. It's going to be gone. You're going to be deaf in that side. And then there are some difficulties because it's a purely transmastoid approach, so you have a smaller window than you might have if you went retrosigmoid. So these are a couple of videos. This is not. I can't take credit for this one. This is from my training. This is from Dr. Pashkaya. I had a couple of videos, and then when I was going to make this talk, my entire video drive was corrupt, so I think I lost all of them. But this is a patient that presented with hearing loss, dizziness, and some balance trouble. And so you can see here that the brainstem is very much compressed, by this partially cystic tumor. These partially cystic tumors are a little bit tougher to treat in a lot of cases because they tend to be stuck to things, and the chances of having a facial nerve palsy is much higher, what we think. You can see this is the area of the internal auditory canal right here. You can see the tumors growing out into that area, and you see these cystic components here. this is how we do the surgery. So typically I do these in a supine position, okay? I'm just going to pause this for 1 second just to show. And this is the anatomy of the internal auditory canal, okay, up here in the corner. And so there's 4 nerves essentially that run in that area, and it's a small tube. And so if you look from anteriorly toward the face, you have the facial nerve, which is superior and anterior. You have the cochlear nerve, the hearing nerve, which is anterior and inferior. And then posteriorly you have your 2 vestibular nerves, and this is a bony crest here called the Bauer or the transverse crest. And so that's the anatomy of these nerves. Typically, most vestibular schwannoma grows from the superior vestibular nerve. There's a few of them that grow from the inferior vestibular nerve, and later when we talk about, talk a little bit about middle fossa. Middle fossa comes from the top, and so if you have a tumor that's from the superior vestibular nerve, middle fossa is a great approach because the facial nerve is out of your way. But if it's from the inferior vestibular nerve, the facial nerve is going to be the first thing that you see. It's right between you and the tumor, and the outcomes for that are not quite as good for facial nerve preservation from a middle fossa approach. So I just wanted to make that point. This is, we make sort of a curved incision back behind the ear. This is the top over here. This is the superior part. The ear canal would be external, the canal would be right up here. And so this is the drilling of all this mastoid bone. Okay, so you have to drill basically the entire mastoid bone completely away. Back here, what they're drilling over now, this is going to be the sigmoid sinus, and this is up here, it's called the tegmen. This is up at the temporal dura. So we remove all that, and now what you're left with down here is where we're getting into sort of the middle ear. And you're going to see the semicircular canals, which are the vestibular apparatus. So they're going to drill those out, and that's when hearing becomes lost. Down, this is near where the jugular vein is, the jugular bulb. And so now they've exposed, this is the internal auditory canal right here, okay? You get 270 degrees of exposure all the way around the canal. Now this is what I mentioned, you're going to expose the facial nerve. So remember I said that's superior and anterior, so the facial nerve is going to be up in this area. And this tumor that's probably growing from the superior vestibular nerve is right here. So then we start to open the dura into the posterior fossa by the cerebellum. And now you're seeing some of this tumor. So now this is the tumor here. They're going to start debulking the tumor. Send some for pathology. And then we debulk, basically, it starts to debulk the entire tumor. This is the parts of the cystic component here where it's going to be attached to the brainstem. And so we kind of remove these in sort of a piecemeal fashion, but the idea is that we this is the vestibular nerve here. Okay, this is where the tumor is arising from. So we've cut that now. But the sort of the key to these is we debulk the inside of the tumor, and then we remove, we collapse the capsule upon itself, and sort of take it out that way. But like I mentioned, these tumors that are very cystic tend to be very stuck to everything. And so we use nerve monitoring during these cases. This is the nerve stimulator here, and it works also pretty well as a dissector. But we can use that to dissect this tumor off of the nerves. This is the brainstem over here. And so now we're using this to dissect this tumor off of the facial nerve. Stimulate and see. You can see that you can't really tell where the nerve is. It's very much splayed. It's a very thin veil of tissue that kind of comes over the top of the tumor. So you really want to find that and try to preserve that. And then generally, if that nerve stimulates at the end of the case, most of these patients will wake up with a facial palsy. But most of those patients also will be gone by 3 months. So it'll be better. So the facial nerve doesn't take a joke very well, but unfortunately it's one of the more sensitive of the nerves that we have, and so working around it is a little bit challenging. And here's the removal of the last part of this cyst wall. Here's the brainstem beneath. And then this is how we close this kind of stuff. The ENT, the neurotology guys will pack some fat into that area, into the mastoid to keep the spinal fluid leak from happening. Because, well, obviously you can't close the dura here because it's kind of just obliterated. So we pack fat into that area and then close it up. Oh, sorry, just got a little bit out of order. This was the final result here. You can see that now the mastoid here is all packed with fat, the brainstem is decompressed, and the patient's facial function is fine. Okay. These are go back here for a second. These are the two cases that I did here earlier on. This was a 40-year-old lady that had had previous retrosigmoid resection of this tumor, and then it was subsequently treated with radiation. And so these are kind of the patients that really are going to be surgical candidates. She had previous surgery, she had radiation, this tumor was growing despite that. And so we did translab resection for her. Her facial nerve was stimulating fine at the end of the case, but she ended up with a very severe facial nerve palsy, grade 5. And that has mostly persisted. She also had a number of complications with infections and spinal fluid leaks and whatnot. You can see that this was a very small window. This is the sigmoid sinus here. You have to go in front of this, so the only window that you have to the tumor is here. Whereas retrosigmoid, you do have a little bit bigger approach. But in patients that have had previous surgery and have scar tissue and radiation, you're almost certainly going to have a facial nerve problem going retrosig. We got it going translab as well, but it worked out okay. This was another patient that had previous surgery. She had this cystic tumor, large cystic tumor and brainstem compression. She had balance problems, and this was another one I did translab. And you can see this particular one, and there's some evidence for this now. I did leave a little bit of tumor on the nerve because rather than give the patient a permanent facial palsy, peeling this tumor off the nerve that had been previously operated on and had a lot of scar tissue, you're probably better off to leave a little bit there, and if it ever comes back, you can radiate it. The retrosigmoid approach, we'll talk just briefly about that. The advantages here, you have possible hearing preservation because you're not going through the middle ear structures, the semicircular canals. You have a better exposure of the brainstem because that's the first thing that you will see, and it's a lot easier. You don't have to do all that drilling that I was showing on that last video. The disadvantages, though, you're working by the cerebellum, they do get some cerebellar swelling sometimes. You can't get the lateral internal auditory canal, so if the tumor has a large extent out in that area, you're not going to get into that. And these patients do have similar types of symptoms after surgery to a lot of the cases that we do. They'll have headaches, they are a little bit more sore and take a little bit longer to recover. If you look here at these tumors, this was a patient whose tumor kind of extends out into the canal a little bit. You can see here, and then this is another patient that has hearing, but it's not quite as far of an extension. So this is how we choose sort of between retrosigmoid versus middle fossa. And then here's one more video. This is showing, so you have a little bit bigger exposure here. You can see this is now a retrosigmoid approach. And so the first thing that you're going to see is the tumor here. Okay, this is the vestibular nerve again. And we're separating that away from the auditory nerve. And so this is the large cistern, though, that you have this large exposure as compared to the approach that you're taking from translab is a little bit anterior to this. So you can debulk this tumor. And then ultimately, you've debulked everything outside of the canal, so now we're seeing where the internal auditory canal is. We're going to open the dura around that, and then you can actually drill the canal from inside as well. Split this up a little bit, maybe. So here we're just drilling the bone around the internal auditory canal to be able to reach that tumor and pull it out of the canal. You don't get quite as good of an exposure of the internal auditory canal from this approach, but it's not bad. And then opening the dura that's left there. This is the tumor here. Pull that out and cut the opposite end of the superior vestibular nerve that's holding the last bit that's holding the tumor there. And that'll leave the facial nerve and the cochlear nerve intact here in the canal. So this is the opposite side here, but that was the facial nerve, and this is the cochlear nerve is inferior down here. That's basically the end of the tumor removal there. There we go. So now if you look at, the literature is not great, and I think Dr. Nelson's going to talk about this as well. The literature really isn't great looking between radiosurgery versus surgery. And these are the hard population of patients, I think, to randomize. There are no randomized trials, but if you look, here's the complications. You would expect surgery probably to have a broader range of complications because we've opened the skull. There's a chance of wound infection, there's a chance of spinal fluid leak, rhinorrhea, and hydrocephalus, things like that. And in terms of stereotactic radiosurgery, people will have more vestibular symptoms, they'll have tinnitus, those kinds of things. If you look at now these studies, they're really, the take-home here, I'm running out of time, the take-home though is that there's not a big difference in terms of the complication rates. Here you can see that if you look at the tumor size, okay, so as the size of the tumor goes up, the complications increase. Here they had facial nerve weakness in 5 patients in the surgery group and 2 of the stereotactic radiosurgery group. And the hearing preservation in this group was better. This was not statistically significant in that particular study. If you look at outcomes, tumor control is pretty equal, okay, between the 2 groups. And then if you look at facial nerve preservation, here the stereotactic radiosurgery group was significantly better. Okay, so I mentioned that in the perioperative period, about half of these people had a facial nerve palsy when they woke up from surgery. Most of those do get better, okay, depending on if, especially if the nerve was stimulated at the end of the case, they get better, and most of them will get completely better. But it is a bit of a problem, and you can see here it's still almost 40% of people had some degree of a facial nerve palsy late. And then if you look at hearing preservation, the hearing preservation rate was significantly higher in this particular study with radiosurgery. Then if you look at the outcomes here, surgery had a little bit of an edge in improved, some of these improved outcomes. Headaches were higher in surgery. Okay, balance problems were higher with radiosurgery. And then the one other thing that is a bad complication that people get often, or well, not often, but maybe up to 30% of the time with radiosurgery is trigeminal nerve symptoms, so facial pain. That can be a real problem that bothers the patients a lot, and it hurts. I'll skip through a little bit of this stuff a little bit faster here. Here again, good results for hearing preservation, 81% in both groups. Hearing preservation, 44% in both groups. So this was very close. This is a meta-analysis. Looked at a lot of patients, a lot of different papers, and so the results were very similar. Here again, you see this was 36% of patients had trigeminal nerve complications. Permanent complications from either trigeminal nerve or hydrocephalus in 15%. Permanent complications of only 5.5% in the surgical group. So you have a little bit better control of things like hydrocephalus and large tumor size. But you have to control for that, and these are meta-analysis, so these studies don't control for that kind of thing very well. And then here's the good prognostic indicators for hearing preservation: small tumors, less than 2 centimeters, minimal extension into the internal auditory canal. That's a good prognostic factor. And then the ENT guys, the neurotologists, can test some of these things like the sapital reflex or this electromystagmography, which can tell you which vestibular nerve the tumor is growing from, which can help to determine this kind of thing. And then we have some modifications of the surgery that can help with this. We monitor all of these patients with brainstem auditory evoked responses and facial nerve monitoring. And then we will release some of the CSF. So if you can release some CSF, that takes some of the pressure off. You don't have to retract as much, and the outcomes are typically better. Papaverin is a vasodilator that maybe takes care of some of those vascular complications that I mentioned. This is another large study. I won't go through this in great detail here, but for hearing preservation, 93% of the patients had facial nerve grade 2 or better, so that's a very good facial nerve outcome. And hearing preservation was achieved in about 40%. Again, you can see as the tumor increases in size, the chance of preserving the facial nerve goes down, and the chance of preserving the hearing goes down again, so that's another big consideration. And then I talked about long-term hearing preservation. You can lose hearing from both surgery and from radiosurgery. Okay, there's progressive fibrosis of the cochlea that's been seen sometimes theoretically from loss of blood supply in the surgical option, and then there's a lot of hearing loss at 10 to 15 years we're finding from radiosurgery because of radiation to the cochlea. Same thing here, we had 40% progressive hearing loss compared to the contralateral ear. And then really this is the gist of it. This is from a Cochrane review that reviewed all of the same literature that both of us are going to talk about, and just basically says there's no high quality evidence in the literature to determine whether stereotactic radiosurgery is in any way preferable to microsurgical resection or observation. So we really don't still know what to do. Okay, that's the gist of it, and I think it's a very individualized basis. Depends on the patient, depends on the surgeon, and really depends on what your goals are. If hearing preservation is not a clear goal, it opens up a lot more options, or if they don't have serviceable hearing to begin with.